Hi everyone, my name is Brad Stiehl and today I'll be presenting a quantitative analysis of lung elastography performance using large deformation CT scans acquired at residual volume and total lung capacity. This work involves and affects patients suffering from chronic obstructive pulmonary disease, or COPD, a progressive lung disease characterized by a reduction of airflow and impediment of breathing efforts due to narrowed airways. Important to this study in particular is the dependency of normal lung function on the elasticity of lung tissues. It is known that COPD causes a loss in tissue elasticity, making it a good measure of disease. Current methods of diagnosis, however, are based on symptoms and presence of airflow obstruction, so they do not describe the heterogeneity of the disease. Patients with lung disease, such as COPD, often receive CT scans at residual volume and total lung capacity in order to assess overall lung function and candidacy for interventional surgeries. Previous publications from our group have proposed a well-validated biomechanical model which provides useful information about regional lung function through recognition of the reliance of lung tissue on certain mechanical properties. We have demonstrated the feasibility of elastography as a novel biomarker for COPD staging according to GOLD criteria. Using this method, regional biomechanical phenomena, such as air trapping, can be characterized. High levels of error in previous registration attempts of large deformation image pairs have made performing accurate biomechanical model-based elasticity estimation infeasible. However, using a published registration technique, PTV-Reg, improved registration accuracy has been observed. Therefore, the purpose of this study is to assess the feasibility of performing lung elastography from breath hold, residual volume, and total lung capacity CT scans. For this study, we retrospectively analyzed pre-surgical residual volume and total lung capacity CT scans for 10 patients. The images were deformably registered using the published registration technique, PTV-Reg, a parametric image registration that utilizes isotropic total variation regularization and has been shown to successfully approximate anatomical sliding motions. The resulting deformation vector fields serve as input to the biomechanical model for further elasticity estimation. Our elasticity estimation method is posed as a parameter optimization inverse elasticity problem where we use a forward finite element model to solve. This involves an iterative process in which the elasticity of each voxel of parenchymal lung tissue is repeatedly adjusted. A deformation according to the registration DVF is attempted, and the displacement convergence level is evaluated. Once a convergence threshold is met, elasticity and displacement distributions are output and analyzed. Across the 10 patient datasets analyzed, mean convergence between model-generated and registration displacement within 1 millimeter were 93 and 93.4% for left and right lung respectively, and within 2 millimeters, 98.7% for both left and right lungs. The average maximum displacement for these patients was 40.7 and 35.2 millimeters for left and right lung, and the average mean displacement observed was 16.3 and 14.9 millimeters for left and right lung, respectively. To further evaluate the agreement between model and registration behavior, Jacobian values and their convergence levels were calculated from the resulting deformation vector fields. The average convergence of Jacobian value within 0.2 was 72.8 and 76.6% for left and right lung, and within 0.3, 85.9 and 88% for left and right lung. The average mean Jacobian values across 10 patients were nearly identical at 1.25 and 1.2 for left and right lung for model-generated Jacobian, and 1.25 and 1.2 for left and right lung for registration-calculated Jacobian. For a visual representation of the measurements and values we have discussed, the example images going from left to right and corresponding to the residual volume source CT images on the left include the model displacement, the registration displacement, the error observed between them, and their resulting elasticity distributions. In conclusion, we observed a high level of agreement between registration and model-generated DVF measurements, including displacement value convergence and Jacobian calculations, showing the feasibility of performing lung elastography using residual volume and total lung capacity scan pairs. Future work will include performing the elastography process on post-surgical images and analyzing the consistency of measurements in the contralateral lung and potential changes observed in the ipsilateral. Additionally, these elastography measurements are necessary to inform biomechanical model-based simulations of surgical interventions and pulmonary function tests that we hope will serve as a tool for patient selection. I'd like to thank my collaborators and colleagues, and thank you for listening. I'd be happy to answer any questions.